Welcome to the Helping Conversation, an exploration and celebration of the practice, art, and science of facilitating trusting, safe, inclusive, and effective helping conversations with others. The helping conversation is at the core of the sacred partnership between two people when one is there to help the other. Recorded at RockVox Recording and Production Studios, Rochester, New York. Find your voice and broadcast it to the world at RockVox, rockvox.com. And now your host of the Helping Conversation, Keith Greer.
Good morning, everybody, and welcome and thank you for joining us on this episode of the Helping Conversation. So glad that you could be with us, and we're going to dive right into our conversation with our very special guest this morning. So join me in welcoming into the Helping Conversation studio, Dr. Patricia Halligan. Good morning.
Good morning, Keith.
So let me share with everybody a little bit about who Dr. Halligan is and her background, and then we'll get started because there is much to be learned from Dr. Halligan on how to do a helping conversation. So Dr. Patricia Halligan is an addiction psychiatrist. She is double board certified in General and Addiction Psychiatry. She completed a fellowship in addiction psychiatry at the Medical University of South Carolina in 1998 and has been treating people with addictions in inpatient, outpatient, and private practice settings ever since. For the past 22 years, Dr. Halligan has focused almost exclusively on providing consultation, individual and group therapy, and medication management for people struggling with addictions. So again, please join me in welcoming Dr. Patricia Halligan. So thank you for making the time. I do know that this is an incredibly busy time in your life.
Yes, sir. Moving on Friday to South Carolina and closing down a practice.
Oh, I can't even imagine. You and I were talking before we came on about the all of the details involved in selling a place, buying a place, and you're moving a few miles down the road.
But I'll tell you, it's really nice to be here in this room because I can forget all that for now.
Good.
Just have a conversation with my friend Keith.
Awesome.
So this is a bit of a break.
Good. I'm glad we could serve a purpose like that.
Mm-hmm.
So I always start in our conversation with our guests, try and start from the beginning. So here you are 22 years or so into a very successful practice as an addiction psychiatrist. How did this get started that resulted in you being where you are today?
Okay. So I never wanted to be a psychiatrist. When I was young, I wanted to be an English teacher.
Oh, wow.
And that's all I ever wanted to do.
Yeah.
But I graduated from high school in Canada, and there were no jobs for teachers in the province of Ontario. All my friends who were becoming teachers, they were going on to substitute teach for, 2 to 5 years. And so I didn't want to do that. So I had a conversation with my mom, and she said, well, women do one of two things. They are teachers or they're nurses. So I went into nursing school and got a Bachelor of Science in Nursing. And then I was working at the Hospital for Sick Kids in Toronto.
Right.
And as a nurse, and straining my ears to listen as the doctors would go on their rounds and talk about all the pathology and the physiology and the biochemistry and the medicine. And I desperately wanted to go to med school. So then I went to med school.
Okay.
And I wanted to become a pediatrician. But I got rerouted. I think you have to be flexible. I just think you just have to be, it's cool from this vantage point at this stage in the game to look back over my career and take a look at all the life events that got me to a place where I could work with people struggling with addictions.
Right.
So in med school, I married a fellow in my med school class, and he developed a really bad addiction to crack cocaine. and cost him his residency.
Wow.
He had to leave a surgical residency program on 2 different occasions.
Right.
And that is the way his recovery began. And when I was, I guess, somewhere along that road, I decided to specialize in um, addiction medicine.
Right. Right. So I'm curious, when you said you made this decision after being a nurse for a while to go to med school, and it sounds like, in some ways you grew up in all of our families were probably somewhat similar in our day,
Mhm.
around a little bit traditional about
Yes.
sex roles and jobs. So I'm just curious how that announcement was met by like your mom, who said, "Look, there's really only 2 places for you to go as a woman."
I look back and I just don't really realize why. I was really great in science and math. And I just kind of wonder why there was a lot of complacency around or disinterest
Right.
in, what girls could do,
Yeah.
but also my own willingness to do what I was told.
Yeah.
It's like,
Right.
okay,
Yeah.
I guess
Yeah.
I'll be a nurse.
Yeah.
I guess it's been a great journey in developing my own voice
Right. Beautiful.
and knowing
Yeah.
myself
Yeah.
over the years.
Yeah.
And yeah, it's really it was a different generation
Right. Yeah.
for sure,
Right.
right?
And knowing your voice and knowing yourself, we'll dig a little bit more into that. So important
Hmm.
for folks who facilitate a helping conversation. So
Yeah,
I want to take a step back even earlier.
sure.
If you look back even to childhood, any indication back then, as you look back now, that you were destined to do something helping others?
I think so. I remember my grandparents had a cottage in northern Canada, up on Georgian Bay,
Right.
and we had bird houses, and the baby birds sometimes would fall out of the nest. And I was the kid who would be running to pick up the baby birds and put them in a shoebox and try to nurse them back to health. And they all died by the next morning. I'd be feeding them, droppers full of water or milk. I probably drowned their little lungs. I
Right.
don't know
Right.
I didn't know what I was doing. I'm better with people. Uh, good thing, right?
Good thing.
And then I remember my brother Mike, he had eye surgery when he was 4. And I spent the day, I don't know where my parents were, but it was my job to stay with him in the hospital.
Right.
And I can remember just going around rocking all the little sick babies, like always drawn to movies about human suffering,
Yeah.
like Helen Keller, and reading books like The Hiding Place,
Hmm.
Corrie ten Boom. And um, so I guess that's just sort of an internal thing.
Right. Yeah.
Yeah,
Yeah.
absolutely.
Which I find I've always said, I don't think it's a coincidence that
Mm-mm.
those of us drawn to this work, we're drawn to this work. That probably based on some inherent ways of being from the moment we came into the world.
I think it would, if you didn't like helping people,
Yeah.
I think you would hate being a therapist. I really,
Uh-huh.
right. I mean, yeah, there's a certain personality type, I think,
Yeah.
from a young age,
Right.
right?
Right. Yeah.
Um,
No, I would agree.
and then you know what, Keith? I think I look at the time also, and I grew up Catholic, and it was going to church was a big part of growing up years. So um, we were always praying for a spirit of mortification. I didn't even know what that was, but
Right.
praying the rosary, praying for a spirit of mortification, and I got one, good or bad.
Yeah.
You're learning about the Beatitudes and make me a channel of your peace and all that good stuff, right?
Right.
Helping others, service of others. It was, it was sort of part of my world, I
Right.
guess.
Right. So as you entered, whether it was your training in nursing and practicing as a nurse, and then to med school and psychiatry, role models along the way, people that inspired you.
Okay. So that's a tough one. I had people that believed in me.
Mm.
My dad, for one, probably my biggest fan on the planet, and my grandfather a close second.
Right.
Um, so I had a lot of support
Right.
and people that believed in me and never questioned me and um, uh, were there every step of the way. And in terms of role models, I didn't find them until I was already a psychiatrist.
Okay.
I had one magnificent role model when I did my fellowship, and that was Dr. Kathleen Brady at the Medical University of South Carolina, and she was my mentor.
Right.
And this woman was the president of the American Academy of Addiction Psychiatry. She was running research into PTSD, cocaine addiction, and women at MUSC, and she was South Carolina's Woman of the Year.
Wow.
And she believed in me.
Yeah.
And I can remember my first day of fellowship thinking, the only thing I'm good for here is like I could make her coffee. She's impressive. She's
Yeah.
just so impressive. And the first patient she gave me was a med student with a heroin addiction who was the son of a local attorney.
Mm.
I mean, she had a lot of faith in me. And I
Yeah.
knew I didn't know much. That's my first day of addiction training, right?
Right.
And she was so impressive. And she was also the mother of 3.
Yeah.
And so she was the first. And then I guess supervisors that I chose along the way, whether they were supervisors to train me in doing therapy or supervisors to run groups or supervisory helping me treat people with sex addiction,
Right.
to help me specialize and better my trade. I've been so impressed by those people.
Right.
My mom, actually, if we take a look at mentors from a young age, my mom had the capacity to make you feel like you were the only person in the room. She was gentle and she was loving, and she had, I don't know, she had such a knack for just making you feel very, very, very connected. She was very, very attuned, probably the most attuned person I ever met
Right.
in a loving way.
Yeah.
So she probably, I guess, in terms of influencing me the most, outside of starting me on the wrong career path that took like a decade to get it right. I won't hold that against her. But yeah, I guess she would be my the biggest influence in terms of loving attunement.
Right. Right.
Mhm.
Right. So you made this choice to not only move into psychiatry, but addiction psychiatry in particular. And I'm thinking 22 years-ish ago, there probably were not a whole lot of people doing addiction psychiatry.
No, so I started my addiction psychiatry in '97, the fellowship,
Right.
and addiction psychiatry fellowships didn't appear on the scene until '92. So they were only 5 years old.
Right.
And it took about 15 years after '92 before we saw addiction medicine fellowships. So this specialty is relatively new.
Right. Right.
Yeah,
Right. Yeah, that's not a long time.
not a long
That's
time
not
at
a long
all.
time.
No. And we're desperately in need of, an expansion of addiction fellowships across the country. It's addiction's not taught in med school. I went to Georgetown, and the amount of addiction that I was taught at Georgetown wouldn't have filled an hour.
So I've always heard that, and
Mhm.
are you under the impression that is still true to this day? That if someone entered med school right now?
I don't think you get more than a token number of hours,
Right.
which is really, really sad because, 10% of the population in our country has an alcohol or a drug problem.
Right.
1 out of 10,
Right.
at least.
Right. Right.
Yeah.
Which means they're walking in the door of every type of doctor. Maybe not with that
Yes.
as the presenting problem, but
Yes.
that's walking in the door.
Absolutely. And if you take a look at psychiatry, for example, there's so much comorbidity that goes hand in hand with alcohol and drug problems. People with alcohol and drug problems also have anxiety disorders and PTSD and depressive illnesses, and bipolar actually is the number 1 most common diagnosis.
Is it really?
Among the addicted population,
Right.
among the
Right.
substance abusers.
Right.
So psychiatry sees a great deal And unless you're looking for it and know how to ask the right questions,
Right.
uh, or maybe if you don't feel experienced enough to treat it, you might actually avoid those issues.
Right. Right. Yeah.
Or sweep them under the
Or
rug.
sweep them under the rug.
Right.
So I was going to ask this a little bit later, but I'll ask it now because you and I were talking about it before we came on, and it seems so relevant with this topic, and that is this issue for us helping people of transference. And the importance of us understanding it. So for folks who are listening, could you just first define what that is, and then the importance of transference in your work as a helping person?
Certainly. So it's interesting. I went to New York Hospital for psychiatry residency training, and there was almost zero lecturing case studies involving transference. 4 years of psychiatry residency at Cornell,
Really?
and transference was hardly touched on at all. So I was not prepared when I went into private practice for some of the reactions that my patients would give me, or some of the feelings that I developed toward the patients.
Right.
That I was blindsided by this, and I really didn't know what was happening. So transference is the basic notion that whatever feelings the patient had in his or her relationship with her mom and dad, primary attachment figures,
Right.
then those feelings are going to be reenacted with me.
Right.
So, for example, if the patient was raised by a critical father, at some point during our work together, he's going to, feel criticized by me.
Right.
Or if he grew up being disappointed chronically by his mother, he's going to expect my reactions to be disappointing. He's going to imagine my responses to him are disappointing.
Right.
If he's going to think, for example, I have one patient who always told me about his dad, who was an alcoholic, and his mom worked all the time. And he would recount a picture of, I used to come home after school, and my dad and I would sit on the couch, and my dad would be drinking, watching news, and I couldn't speak because he would tell me to be quiet. And I always felt like I was dull, boring, and uninteresting and annoying. So he always thought that I found him uninteresting
The same.
and boring.
Right.
And it couldn't be further from the truth.
Right.
Or sometimes the feelings will be induced in me. So if, for example, this child had parents that always told him he was a bother, a burden, frustrating, and they were maybe the parents had murderous rage toward the child, and it was a bad fit.
Right.
Maybe the child had a learning issue. I remember one fellow I treated, his dad had written 30 books, and he was a professor and world-renowned, and this child had dyslexia, ADD, and learning disability, and desperately wanted to please Dad, but Dad was ashamed of him, and Dad really didn't like him, and Dad sent him from, to one boarding school after another.
Right.
And after sitting with this man for, I think like 11 years, after half of that time, I started finding him very frustrating. And he was unconsciously setting it up so that I would have similar feelings toward him than, that his father and mother had toward him.
Yeah.
So it's not enough to just be a good listener and care about the patient. You have to be skilled and an expert, like when you're managing somebody's transference, so you don't punish the patient.
Right. I would also imagine, because in my background, in family therapy, we would talk about this from the standpoint of family of origin kinds of issues. So it's not just about, though, those kinds of issues that your client or your patient walks in, because we're a human being too, right? And we're walking in with our own stuff. Right. As I said to you, I sometimes, when I train coaches and clinicians, talk about being aware of who walks in the room with you, into the helping room from your past that influences your work, often not in the greatest of ways. So
Yep.
this is complexity on top of complexity that I think many people don't appreciate who aren't in the helping professions.
Oh, for sure, Keith. So if for example, you're raised by a drug addicted father who is screaming at your mother all the time and is a bully and beating up on your siblings at the dinner table, and you have a patient who is can be a bit of a bully,
Right.
it's really, really important to be taking those feelings toward him
Right.
to your supervisor
Yes.
and to your own therapist, because otherwise you're going to want to annihilate him.
Right.
And,
Yeah.
right.
Yeah.
And
Right.
and it's not fair to him.
Right.
But then you're blurring the lines,
Right.
and you're projecting feelings that you had toward your father or
Yeah.
toward your mother onto the patient.
Right. Right.
It's so important to keep, 2 steps ahead of your own baggage.
Yeah. Yeah. Right.
Right?
The other way I sometimes think about it is that what you just described. So I am the helping person, and I
Mhm.
walk in with this stuff with my dad. That it robs me, if I'm not insightful about it, it robs me of the ability to actually be present with my
Yeah.
client
Right.
in present time. I'm in the
Right.
past somewhere,
Yes.
and the past is walking in the room.
And how distracting.
Yes.
I love that point.
Yeah.
Absolutely. Yeah, you want to be 100% open to the patient, and you don't want to be reacting. You want to be monitoring your own reactions
Right.
and using that to help you understand what's happening between the two of you.
Right. Right.
But you don't want to be distracted in your own psychic mess.
Yes. Right.
You, it's so important. Like, for example, with my own situation with my ex-husband when he
Right.
developed the drug addiction, if I hadn't done a lot of grief work around that, and I was working with a woman whose husband had an alcohol or a drug problem, and she was grieving his, leaving the kids, leaving you, um, and feeling very distraught and needing time and space to grieve.
Right.
If I haven't done my own grief work, I'm going to shut her down,
Yeah.
and I'm going to want to switch topics.
Right. It's uncomfortable for
Or
you.
you bet. Or
Right.
I'm going to minimize her pain.
Right.
Moving on now.
Yeah.
It's
Yeah.
and that's so not fair. So you don't want to cut yourself off from your own reactions because, for example, back to the bully,
Right.
say this guy is misogynistic and he has a misogynistic part, and as a woman, you're reacting to, wow, I'm feeling hated. You want to sort of approach it with an air of curiosity.
Curiosity.
I wonder where that comes from.
Right.
I wonder how he was treated as a child. I wonder who hated him.
Right.
I wonder if there's shame involved,
Right.
or maybe he's got anger issues, or maybe he was, he's got PTSD and
Right.
this is some kind of reenactment. I'm not sure, but you don't want to be quick to react or shut them down or punish.
Right.
Everything has to be approached with curiosity.
Yeah. It also strikes me that for us as the helping person in working with transference and countertransference, and I find this again in some of the training that I do, that this is a really scary place to go for new helping people. It's a
Oh.
very scary place to go. And no matter how much I might say, it's a really good place to go. It's one of
Mhm.
your greatest learning opportunities. It's really scary to go inside and get curious with yourself about this stuff that maybe I've been keeping at arm's length
Right.
for many, many years.
But I'll tell you something. It's you can get hurt. To your point,
Yes.
you can get hurt, and you can hurt your
Your
patients.
patient.
And the first thing I always advise newcomers is, if you're going into private practice, first thing you do, get yourself a supervisor.
Yeah.
For many different reasons.
Right.
But one would be so that you don't hurt the patient.
Right. Right.
Above all, do no harm.
Do no harm. That's it.
Right? The Hippocratic Oath.
Yeah.
And also, it's very freeing to be able to go into a supervisor and say, I hate her,
Yeah.
my patient.
Yeah.
I hate my Tuesday morning at 10.
Yeah.
I want to fire her. I can't stand talking to her. I have to dig my nails into my palms of my hands to keep from yawning or screaming.
Yeah.
And I need your help figuring out what is going on.
Right. Right. For you.
For me.
Right.
Right. And then, like, it's good to know, I'm not all good, right?
Yeah.
I don't have just good, kind, loving, warm, attentive thoughts.
Right.
So if I want to kill this woman, probably everybody in her own inner circle does too,
Right.
right? And it frees me up to say it and put words to it,
Yes.
because then I'm far less likely to act it out.
Right.
Or with my population, for example, the addicted population, there's some very seductive folks that walk into my office, and you probably have
Yeah.
found that
Yeah.
doing coaching.
Right.
So it's really, really, really important to be with a supervisor to help keep the boundaries really firm,
Yeah.
so that if you get a seductive client who is flattering you and saying all sorts of lovely things, you want a supervisor to work closely with you and keep you aware of the fact that it's really not about you.
Right.
It's really about the patient.
Yes.
And watch when the seduction happens in your office. And chances are it's either an attempt, by this patient to avoid their own shame,
Mm-hmm.
or it's a power play,
Right.
or they're trying to make you uncomfortable, or it's maybe if I flatter you, then you will treat me special.
Right.
If I treat you
Right.
special. But whatever it is, be wary, because you really want to be firm with your boundaries. You don't want to compromise the trust relationship.
Right.
You don't want to overstep any boundaries. There's where supervision can come in.
Yeah. It's so important.
So important.
Right,
I mean,
right.
so yes, in answer to your question, very dangerous place to somebody entering private practice who doesn't have a supervisor.
Right.
And if you don't have a supervisor that knows what they're doing, pay privately. I paid privately
Yeah.
for
Yeah.
supervisors
So did I.
from day one, right?
Yeah.
Yep, for like an hour a week. I remember this was like, boy, so this was 2000 when I went into my first private practice, and I was paying $150 an hour
Mm-hmm.
then. That's 20 years ago,
Yeah.
once a week.
Right.
And it's also very comforting because, Keith, I remember the first week of private practice, and everybody I'd ask, I'd say, well, what do you want out of your therapy? And a lot of times they would say, I want to be more comfortable in my own skin,
Right.
and I want to experience joy, and I want to be authentic, and I want to learn how to do intimacy. And I'm like, anything else? Like, I'm like, oh no, like that's just a tall order. And
Yeah.
I'd go home feeling burdened, like, how the hell am I going to help you
Right.
get there?
Yeah.
And so if you go into supervision, it's like, oh, thank God,
Right.
I've got help.
Right. So it strikes me that this issue around our learning around transference is, on one hand, it's us learning about our stuff so
Yeah.
that we don't bring it into the room.
Right.
And then the other thing I heard you say, and I would agree with this, that very often folks that we work with, you could say, as they are in your office, they are in the world. So it's
Absolutely.
such a cool opportunity to help them see some of those patterns that maybe as they walk in, they're not seeing. Which then leads me to the next question, which is to even start that conversation with another human being means that you as the helping person has to immediately attend to how do you create trust and safety when new people walk into your office. So talk a little bit about that.
So, what I've found, Keith, and maybe you found the same thing, is people are usually just looking for a safe place
Yeah.
to be heard
Yeah.
and to be seen and to be known.
Right.
Very few people are really looking for advice.
Mm-hmm.
And when they're looking for advice, like I'm trying to treat a lawyer right now, they're super tough. I've got the toughest are attorneys and neurologists because they're super smart and they're really good at intellectualization as
Yeah.
a defense.
Yeah.
So every week I talk to this attorney and for an hour, and he does everything to keep himself at an arm's length from
Right,
me
right.
because we're in the first 3 months of the relationship. So he always goes back to, now, doctor, let me talk about my medication. And we haven't changed his medication, and we probably won't, but it makes him comfortable. He'd rather do anything than talk about his feelings, and he'd
Yeah.
rather do anything than get close to me. So,
Right.
but the trust, they really want to be known.
Yeah.
They want a place where they can feel safe. And I think part of the uh, safety and the trust, uh, you have to set the stage for the frame. And I think the frame from day one is super important. So patients like rules. They're like kids. Kids in a house feel much safer if they know that there's a set bedtime and dinner happens at a certain hour, and they know what the rules are, and they know that mom and dad are going to enforce the rules,
Right.
and there's no ambivalence. So we start on time, we end on time, and I give you the same slot every single week,
Okay.
so that when the patient will say to me after, usually about the 6-week mark, I've been thinking, maybe I don't need to come every week. Maybe I'll spread it out every 2 weeks or once a month, maybe
Right.
just once a month. Then I'm pretty frank with them and I'll say, if we're doing every 2 weeks, unless you're in my group also, we're just playing catch up
Right.
and it's not going to be enough.
Okay.
I don't do anything that I don't believe in. I will say to every once in a while I'll have a patient and I'll say, I pose it this way. So I understand that you want to come in once a month. I also understand that you want to be comfortable in your own skin and have more intimacy in relationships. Should I gratify your wish and see you once a month, even though deep down I'm feeling strongly that it will
Yeah, that's not
not?
going to make it.
Right, right.
Right.
And then I'll put it back in their lap
Right.
so that they can make the call,
Okay.
as opposed to being authoritarian and saying, I don't work that way.
Right. So if that patient were to decide at the end of the day, well, no, I still want to meet once a month, they have clarity from you at the very least
You got it.
on your worry about how that is going to
Yeah, it'll
mesh with the goals they have.
Right. I think it'll be inadequate.
Right.
And should I compromise my own personal integrity
Right.
and belief here
Right.
and agree with you that it's worth a try?
Right. I also wonder when you talk about like that structure of we start on time, we end on time, same appointment every week.
Mhm.
I'm thinking probably much more so in your world than my world at the moment.
Mhm.
When people show up at your door at first, they're in crisis.
Yes.
And affect-wise, emotionally, are all over the place.
Right.
So I'm figuring that even that structure you're talking about just maybe even helps to kind of quote hold people together at first.
You bet. And I remember one patient that I met a couple of years ago, and he was just out of rehab, and he had a girlfriend who was the daughter of a mob boss who was into cocaine, and he was fresh out of rehab. He had been in rehab for 3 months, and he got to my office, and we talked for an hour and a half, and we set up a time that every Thursday he was going to come in at 1 o'clock. And at the end, I said, okay, do you have any questions? And he looked at me, leaned over, and he said, what am I supposed to do between now and next Thursday at 1 o'clock? So it was a holding environment for him.
Right.
And it was somewhere we become, as therapists, hopefully, the secure base
Yeah.
that they never had.
Right.
Right? Somebody that they can connect to, somebody they can feel safe with, and a place from which they can learn how to do intimate connecting with other people in the real world,
Yeah.
right? And start to explore the world if they have a secure base.
Right. Right. Okay.
Mm-hmm.
So, in your world as an addiction psychiatrist, your clientele are struggling with all different types and levels of either substance use disorder or it sounds like some process addiction,
Yep.
gambling, sex, things like that. So, what are some of the modalities or theories that guide your work specifically with this population?
So I borrow from several camps. So motivational enhancement, I do a lot. And particularly when somebody comes in with family members on day one, and that person might be in denial and might be not really at that readiness to change
Right.
point. So I do a lot in the first hour and a half with the family and the patient to try to move him along that readiness to change continuum.
Right.
And it's so impactful. And I use this if I want to help that person go away to residential treatment. or if I want him to engage in an outpatient substance abuse program, or if I'd like him to consider abstinence for the next 6 months while we try some medications and do a little bit of therapy.
Right.
And I'll bring the family in, and I'll just ask the patient, is it okay with you if everybody goes around the circle and just gives me an idea of what they're worried about and what they'd like to see happen
Right.
in your treatment. And after everybody shares, you'll have a chance to talk, and then we'll meet by ourselves.
Right.
And I will ask mom, dad, girlfriend, boyfriend, maybe if it's an adult, grown children, um, how long have you been worried? And then tell me about the consequences of the addiction, whether it's alcoholism or heroin addiction, marijuana, cocaine,
Right.
Xanax. And so, I'll ask about emergency room visits. Oh yeah, when he was 18, he had a
Mm.
blood alcohol level of, 0.35
Right.
and
Right.
he had to be hospitalized, or he drank, a bottle of Everclear and his kidneys shut down, or accidents, 3 car crashes. Um, has he been arrested? Yeah, a couple of UPM charges, or
Hmm.
maybe for drug selling, maybe a DUI. How many family gatherings has he been late for? How many relationships has he lost? What percentage of dropping out of college did the alcohol and the drugs play?
Right.
So over the hour and a half, the patient listens to this, and it helps smash through his denial
Right.
system, which is such a part of active addiction.
Right.
And then I will ask at the end of the interview how it's been for him hearing all this. And typically they'll cry,
Hmm.
or they're sitting crossed arms looking really mad.
Right.
And then I'll ask, talk to me from the very, very, very small part of you that is worried about the marijuana
Mm.
or the heroin or the alcohol. And they usually say, well, what do you mean? They're very dodgy. And I'll say, not to stereotype, but for the most part, if they don't want to really, they don't really want to talk from a place of, yes, I'm worried too. I'll
Yep.
just ask it again.
Right.
So very, very, very small part of you that might be worried
Right.
that you have a problem. Or maybe there's a very small part of you that's, what are you afraid is going to happen if we do nothing over the next 3 years?
Right.
So it's sort of like, all right, and what are your values? Well, I want to please my parents. I want to be an architect.
Hmm.
I want to keep my current girlfriend. So the drug use and your goals are really clashing here.
Right. Right.
And, what do you propose we do about it? What are the options here?
So you're really, the word I might use, you're really exploring their ambivalence,
You got it.
right? That ambivalence that I want to change, I don't want to change, I want to change, I don't want to change.
Exactly.
Right.
It's wonderful.
Right.
And I love talking to the parents, because what I'll say to the patient is, or the family members, whether it's a wife or parents, the husband, I'll say, no, I don't want to talk to you again. Talk about building trust. I will not talk to your parents, your wife, your husband, your grown kids, unless you're in the hospital or in jail.
Okay.
So I really need them to talk all at once right now in this room for the next hour and a half. Go. Because I won't talk to you in the future, because it's just between us.
Right. Okay.
But they can give me as much information over the phone and leave it on my voicemail if they think I need to know.
Right. But you're not passing anything back to them.
No, they know
Right.
nothing. But
Right.
I will only talk to them if you're in jail or in the hospital.
Right.
And even then, I don't talk about what goes on in our individual work.
Right.
So motivational enhancement is one camp that I come from,
Okay.
and that's the interventionist side of me too.
Right.
And then the other side is attachment theory. So for normal growth and development, the baby needs an emotional attachment to the primary caregiver, and I think that's where a lot of my folks have attachment disorder.
Okay.
I mean, I think alcoholism and drug addiction is an attachment disorder.
Okay.
It's in our DNA to want to connect.
Right.
So attachment theory basically says I have to be the secure base, whether I'm doing individual work with my patient or if I'm putting him in a group.
Right.
And then that will help him see himself differently, see himself the way I see him,
Right.
the way the group members see him, challenge the myths that he was, raised with
Right.
about his own worth or lack of importance, lack of specialness. It also will give him the opportunity to develop some kind of ability for healthy, mature emotional connections going forward. So you asked about the trust relationship.
Right.
I had a supervisor once, the smartest thing anybody ever said to me, among others, but this is probably the thing I would underline, is he said, say this to your patients: don't trust that I will never disappoint you and never let you down. The only thing you ever have to trust is that I will always care how you feel when that happens.
Wow.
And I just thought that is the wisest thing anybody's ever
Yeah.
said. Yet don't trust that I'm not going to, disappoint you and let you
Right.
down.
Right.
I will fail you.
Yeah.
Know that I
Because
will.
I'm a human being.
I'm a human being.
Right.
I'm going to fail you, piss you off, and disappoint you. Know that I will always want to know when you're angry at me,
Right.
and when I've hurt you, I will always care how you feel.
So it's not the hurt, it's whether the person who perpetrates the hurt owns it,
Yep.
takes responsibility, apologizes,
Right.
I care for you.
Yeah.
That's the piece that a lot of your patients walking in, you're thinking didn't get growing up.
Totally.
Right.
And it's the repair that is more valuable than the rupture.
Right. Right.
And this is something that I didn't know walking in.
Yeah.
Right? I didn't know about transference. I didn't know that I was able to make mistakes, big mistakes.
Yeah.
And what a wonderful gift to give the patient.
Right.
Because talk about replicating what happens in the real world. How do you ever learn how to function in an emotionally secure, intimate relationship with other people
Right.
if your therapist doesn't ever hurt you?
Yeah.
Which is another reason, the other camp I borrow from is modern analytic theory.
Okay.
So that is, I was trained to run modern analytic groups. And in modern analytic groups, the patient will get a chance to say to somebody in the group, you really hurt me by what you said. Or I was so infuriated at your comments, Anne, to Paul.
Right.
And you reminded me of my mother. And I just wanted to, I wanted to knock you upside the head, shut you down. It's not an action group, so
Right.
we can put thoughts and feelings into
Yeah.
words.
Yep.
It gives you an ability to see how you come across, too.
Yeah.
Like if, for example, we had a lady in one of our groups who was so biting, caustic, critical, but she'll to everybody in the group.
Right.
And they confronted her with this over time.
Right.
And she could hear her own voice and watch her. She said to everybody in the group, I am a verbal wrecking ball.
Wow.
But what it gave me, I love putting people in groups as well as doing individual therapy with them
Right.
because I get to see another side of them.
Yeah.
If it's just me in a room and you're on a couch and I've got my diffuser on and I got flowers to my left and everything but birds chirping in the trees, that's not very realistic.
Yeah.
But if I put you in a group of 10, you're going to be pissed off because I'm not going to be paying you enough attention.
Right.
And, the girl who's number 8 out of 9 children, these are her issues.
Right.
She's going to be jealous. She's going to be disappointed in me. And she's going to get a chance to say this out loud to me
Right.
and see how I respond.
Yeah. Right.
So
Right.
I love modern analytic group theory.
Yeah.
I love the attachment theory. And they work and put a person in individual and groups. And it's magnificent.
That's awesome.
Right?
So I'm very mindful of the time because
Yeah.
you and I could sit here and talk for 4 hours.
Yeah, this is fun.
So I want to jump to your use of evidence-based medications
Sure.
in the work you do with folks with substance use disorder. Because as you and I know, and we've had this conversation, there is still so much misinformation out there, so much stigma, even within the treatment and recovery community itself,
Yeah.
around the importance of us understanding the role of medications, especially around things like opioid use disorder.
Oh, thank you very much. Yes. So this is the advantage to going to med school, is that I'm so glad I can prescribe my own medication to my patients, and I don't have to depend on prescribers in the community that might be hurting my patients.
Right.
By prescribing Xanax,
Yeah.
for example. Yeah, so I guess when I'm treating people, I'm so glad that I have the ability when somebody comes in and they've been 5 years on Xanax and they're telling me that their anxiety is getting worse and their depression's not going away and they're waking up with panic attacks in the middle of the night and their memory is getting worse. They can't concentrate and their mind is sluggish and their daytime sedation is through the roof and their family's worried that they're taking too many pills. I can talk to them about the dangers of long-term benzodiazepines like
Right.
Xanax and Klonopin, and I can help them develop a plan with me to do a long, slow Valium taper and take them off it over the next 10 to 12 months.
Right.
And like
It
that's
takes
exciting.
that long,
For
10
a
to
lo-
12 months.
For a long, well, so let me put that in perspective. My clients use like 10 times the average
Okay.
prescribed dose.
Right.
So people that are abusing it, like people who are on, 3 milligrams of Klonopin a day, 4 milligrams of Xanax a day, that takes a long time.
Right.
Long, slow Valium tapers better.
Okay.
If you do it too quickly, their anxiety is too high and they usually relapse.
Right.
6 month, 3 to 6 months at least.
Okay.
Most of my patients are using so much in terms of quantity that it takes them about a year to get off.
Right. Right.
And with respect to opiate use disorder, there's just so much that isn't practiced in this country. We've got great medications that actually treat opioid use disorder, Suboxone and methadone being two of them.
Right.
And the last study that was released in JAMA in February of 2020 basically showed that out of 40,000 insured people across America, 12.5% got those life-saving medications, and 64% referred to behavioral treatment alone, which doesn't work by itself.
Right.
Abstinence and behavioral therapy alone for opioid use disorder doesn't work.
Right. And yet, you and I both know that has been the pathway of recovery that has been hoisted upon generations of folks with opioid use disorder.
Yes.
And when that didn't work, quote unquote,
Yep.
it was they weren't working a hard enough program.
Right.
So you're saying the research is now telling us we were way off base with that.
So, Keith, the research has been telling us this for like 13 to 20 years.
Okay.
Buprenorphine's been FDA approved since 2002 in America,
Right.
and methadone for 60 years.
Right.
And the research for the past 2 decades is that it decreases relapse and it increases treatment retention and it decreases mortality.
Yeah.
Those two drugs decrease mortality by 50%.
Wow.
And they're not 12.5%
Right.
out of 40,000 people got the medications.
Right. So I will ask you the question that I know you get asked all the time.
Yeah.
But Dr. Halligan, isn't that simply replacing one drug for another?
And the answer is no, because definition of addiction is if I continue to use drugs, even though I experience consequences. I go to jail, I lose my marriage, I go to the hospital, I get arrested, I don't show up for my kids, I get in accidents, I go to the emergency room. But people who are taking methadone and Suboxone, they're keeping a job, they're showing up for their family, they're coaching their kids' games,
Right.
they're staying out of trouble with the law, they feel good about themselves, their head is held high,
Right.
and self-esteem goes up, integrity goes up. That's recovery, not addiction. So
Right.
this is not substituting one addiction for another.
Right. And then part B of that line of thinking is, okay, Dr. Halligan, I can go with you. We'll put this person on Suboxone. When do we find a date to start tapering them off?
And the answer, Keith, is don't taper. So we think that opioid use disorder is like a chronic disease.
Right.
So it's like asthma, it's like diabetes, it's like hypertension. You get them on the medication, Suboxone or methadone, and you leave them on it. It's a lifelong medication.
Right. Right.
Yeah, do not taper. Do not start with small doses. High doses are better. Don't taper. Think long term for years and years.
Right. What is getting in the way? And I'm going to ask specifically within your profession with other docs.
Yeah.
What's getting in the way of this not being a more clearly understood and accepted pathway of recovery for folks walking in with opioid use disorder?
So, number one, it's lack of addiction training
Right.
in this country. So we don't have enough addiction specialists. in America for every person with a substance use disorder. Number two, lack of Suboxone prescribers. We're looking at like less than 6%, 6%, less than 6%, okay, of American physicians are licensed to prescribe buprenorphine,
Yeah.
which is Suboxone. That's
Yeah,
unbelievable.
that's nobody.
And the problem is the system. There is a ridiculous DEA waiver and special training that physicians need in order to prescribe buprenorphine. And hopefully they will do away with that.
Right.
Because physicians go on to think that it's a more complicated medication than it actually is. It's actually really easy to prescribe, and it's a life-changing, game-changing medication.
So I'm sitting here thinking, I might be wrong, that the fact that there is a waiver, is there a waiver for docs to prescribe other medications?
No. Like, okay, for example, in 2003, I went to be trained to become a buprenorphine prescriber. And from that point till now, I could write 500 prescriptions a year for Vicodin. And in my first year of being a buprenorphine prescriber, I could only write for 30 people. Unbelievable.
Yeah. Stigma, maybe?
Yeah, huge amount of stigma. Huge amount of stigma. And our patients are shamed for being on Suboxone or methadone.
Right.
When they're life-changing.
Right.
They're not treatment-assisted medication. They are the treatment for opioid use disorder.
Right.
That's number one thing you do if you have a son who's a heroin addict. You put him on methadone or buprenorphine.
Yeah. So I want to highlight that because you and I just had this conversation last week. So in the world of treatment and recovery, MAT has always stood for medication-assisted treatment.
Right.
And your definition of MAT is what?
Medications for addiction treatment.
Right.
They're not an assist. They're not an adjunct when it comes to heroin addiction or an addiction to pain pills. So let me just clarify. If you're addicted to pain pills long-term or you're addicted to heroin long-term, it's the same brain disease, opioid use disorder. And the treatment is the same. And it's the number one treatment of choice is either methadone or buprenorphine.
Yeah, great. Right. Man, we need to get that word out there because that stigma is alive and well.
And it's killing people.
And it's killing people.
Yeah. Waiting lists are killing people for buprenorphine and methadone.
Right.
And stigma kills them.
Yeah.
And abstinence kills them.
Right.
Anybody preaching abstinence.
Right. Which is that, again, that other part of that accepted pathway that everyone with a diagnosed substance use disorder has to choose abstinence.
In the old days, absolutely. But not the last couple of decades of research.
Right.
We just need to get the word out.
Yeah.
I appreciate you making space and time for it.
Yeah. It's mind-boggling to me.
Yeah.
So one of the other hallmarks for me of a powerful helping conversation is that helping conversations are strength-based. We help people identify their strengths. So I always like asking my guests, what are some of yours? Some of your personal professional strengths that maybe specifically you bring to your work?
I think I borrowed them from my mother. I think I'm a good listener, and I'm attuned. So those would be my strengths. And I know how to. If you've got panic attacks, I know how to get rid of them.
Right.
If you're in a manic episode, I can get rid of that. If you got a psychotic episode going on, I can get rid of that. So depression, lots of options, put people to sleep. I can knock out an elephant if I have to. So that helps. That's a strength, I guess.
Right. So that technical, some might call it the technical skill, right, of being a psychiatrist.
Right.
Right.
I'm also good at building villages for people and bringing resources together. So, for example, if you're seeing me, 1 hour a week is not very much.
Right.
So if you are psychologically minded and relatively likable, I will put you in a group.
Right.
And then that builds a bigger village. If you need emotion regulation skills training over and above what you'll get working with me and in my group. So say you're somebody who struggles with chronic suicidal feelings, or you can't escape feelings of anxiety or depression or self-loathing, I might put you with a CBT therapist on the side or a DBT therapist to teach you about self-soothing and distress lowering.
Right.
So a lot of times therapy alone will do that, just by having that secure base. And I know I'm going to be with you for 1 hour a week. That's calming in and of itself. But for people who need, anxiety management skills training, I don't try to mix my psychodynamic therapy with, I'm going to put on my DBT hat now and I'm going to give you homework
Right.
around,
Right.
mindfulness. But I can give you meditations for mindfulness that are on the web to go listen to. I can give you apps. I can recommend a good AA meeting or an NA meeting. If you need a men's meeting,
Right.
I know where people, I think you would fit,
Yeah. Right.
a different groups for different people, right? And give you 5 to try.
Right.
So I know if parents are struggling with somebody with an addiction, I know how to put them with a family person who knows a lot about working with family members of the addict.
Yeah.
So I'm pretty humble on a good day and try to get, build people a village.
Beautiful.
And that helps me too, Keith,
Yeah.
because I don't want to be your village.
Yeah. Right. And I would add to the list of folks that you refer to, because I know this personally, is that you at times will get your patients to a recovery coach to do some of that work with
I've
them.
loved what the recovery coach can do, particularly for my patients that don't like AA,
Yeah. Right.
or don't like NA, or they don't like SOS or Smart Recovery.
Right.
And wow, what a bonus to have a recovery coach, because it's an hour with me, an hour with the recovery coach, and maybe one of my groups.
Right. Right.
It's so wonderful,
Yeah.
because it's just another way to feel good about themselves, right? And they might also need help around relapse prevention and problem solving, right? And how to structure their downtime without drugs,
Right.
how to have fun without drugs
Right.
or alcohol.
Right.
And they're so lonely when they get into recovery because they have to cut off
Yeah.
people, places, and things.
Right. Right. I usually ask, as we get towards the end of each episode, I usually ask my guests, what you would say to somebody who's thinking about entering this field. So I'm thinking, given the stat you shared of how few addiction psychiatrists there are,
Yeah.
if you had the chance to speak to the world of psychiatry
Yeah.
about coming into this specific niche, what would you say to them?
Oh, I would say it. I would rather sit with somebody with an alcohol or drug problem than people at a yacht club or a golf club or a tennis club or even a book club. These are some of the most grateful people on this planet
Yeah.
for your help.
Yeah.
This population, by and large, they know shame. They are steeped in shame.
Yeah.
And if you call them back, they're grateful. If you extend a hand and shake their hand, they're grateful. If you are loving and non-judgmental, they're grateful. It's the best population. I mean, they just, I don't know, they need your help.
Right.
And they're very grateful for it.
Right.
And I don't know, I find the substance abuse population to be pretty smart
Ooh. Yeah.
and creative
Yeah.
and kind.
Yeah.
Like, you want to see human kindness, go to an AA meeting.
Right.
And you'll see young, handsome men get up and give their chair to an 80-year-old man,
Right.
And put an arm around his shoulder and give him a list of phone numbers and
Right.
shake his hand the next time they see him and say, "Hey, Pete, glad to see you back."
Right.
I mean, it's really, it's very touching. It's hugely meaningful work,
Yeah.
and we need your help.
Yes. And
Wonderful.
and counter to how I think so much of our society views substance use disorder, it's highly treatable.
Oh, highly treatable.
Right.
I had a mentor once. His name was Lou, and he was at New York Hospital on a 28-day rehab during my psychiatry residency. And Lou Mizell, and he's dead now. And I asked him, what do I tell my patients when they ask me what % of us will get into recovery? And Lou said, if you don't drink and don't take a drug every day, and if you make a gratitude list and you call your sponsor and you get to a meeting and you get down on your knees at the end of the day and thank God for your day of sobriety, 100% of you
Right.
will make it. And I just thought, yeah, it's a one day at a time
Yeah.
thing.
Yeah.
But yeah, this is treatable.
Yeah.
This is
Yeah.
100% treatable.
Yeah. So we're almost out of time, but you are in the middle of working on a very special project.
Oh, yeah.
You want to talk really quickly a little bit about that?
Thanks for asking me.
Yes.
And thank you for participating
It was
in
my pleasure.
project. You made the whole video series, as far as I'm concerned, because of your passion for our shared work.
Yeah.
And so Keith and I made 3 videos to teach healthcare professionals about opioid use disorder, benzodiazepine use disorder, and cannabis use disorder. And they'll be available on my website at the end of September, and that's treataddictioninyouroffice.com.
Beautiful. Beautiful.
Thank you.
And so these are directed at docs, at treatment people, at other folks who work, anyone really, I think, who works within the world of substance use disorder.
Absolutely. And even primary care docs or social workers, psychologists who want to better understand if they have a patient who's addicted to Xanax or addicted to cannabis or addicted to heroin or pain pills, what is the treatment that's out there?
Right.
And how do I understand how to help them better?
Beautiful.
It's wonderful.
And thank you. Thank you for inviting me into that. It was wonderful.
Exciting.
And I can say, because I was in the room, the information contained in these videos, especially around this issue of the medications that are evidence-based and research-supported, it's a lot of information and really important for anyone working in the field to have.
I'm excited. You know what, Keith? It's like when you get to a certain stage in your career,
Yeah.
maybe you better turn around and teach.
Yes.
Because I think you can make a bigger impact sometimes by teaching things. That's why I'm so glad you have this radio show.
Yeah.
And I
Yeah.
can't wait to see this series.
Thank you. Thank you.
Yeah.
Well, Dr. Patricia Halligan, thank you so much for sitting in today.
And thank you for having me.
You are very welcome, and all the best with this move. And I know you're only a phone call away, but the Rochester area will miss you.
Oh, thanks, Keith. I really appreciate that. And I hope we keep in touch.
We will.
Okay.
We will.
Thank you so much.
So thank you all for sitting in on this episode of the Helping Conversation. A wonderful conversation today with Dr. Patricia Halligan. Join us the next time for our next episode as we continue to explore and celebrate the practice, art, and science of the Helping Conversation. Have a great day.
We thank you for sitting in on our discussion today on just one unique version of the Helping Conversation. We would love to hear your thoughts on today's podcast, so we sincerely invite you to follow, rate, and most importantly, review our episodes. Please join us for our next episode as we continue the exploration and celebration of the practice, art, and science of the Helping Conversation.